What I'm going to attempt to do is to just real quickly give you some pearls of wisdom on multiple topics, actually, that were presented by an array of individuals on November 6th, so very recently. We will be posting soon, probably this coming week, the actual video recordings of these. So people cannot get credits for watching them, but you certainly can watch them. And some of them are, quite frankly, I've gotten feedback. Every single one of them got great feedback. So what I've done is I'm going to show you, this is the agenda real fast. I am going to cover a number of these because I've already received their slide sets. Dr. Messamore agreed for us to post stuff, but I don't have his slide set. And you've already heard wonderful things from Dr. Torum. So I'll just have a placeholder there for that. You've already heard myself, not Amy, but myself at least, talking about substance use updates. I'll show you one slide just because it dovetails with one of the slides from the first group here. And then I will talk about the alcoholic liver disease and alcohol use disorders. I've not received the slide set yet from Dr. Dorsett. So that's okay for time's sake, since we have a case that's going to be better for all of us, including me, or I'll have to talk at triple speed. So anyway, so I did try to put a placeholder slide in here. Not sure why they sent me the slides. I did that anyway. So at least you'll see who to give credit to, because these are not my slides. I'm going to give you hopefully some pearls of wisdom. So we started, and I put it in the same order as the agenda. So we started with Dr. David Tracy and Dr. Paul Manning, both up at Metro Health. Dr. Manning, as a physician who has moved from primary care into doing a lot of medication-assisted treatment at Metro Health and at the Cuyahoga County Jail. And then Dr. David Tracy, an emergency room physician who is now doing the addiction fellowship. So you'll see here that as Dr. Tracy started, he talked about the opioids, but this, again, a talk I gave a while back, not too long ago. You'll see here, there's a lot of other substances to worry about, not just opiates. And you'll notice here that although synthetic opioids, so again, opioid, think Star Wars and droid, that means it's a synthetic. Opiate means it comes directly from the poppy. You'll notice that although synthetic opioids are still horrible, that's mostly fentanyl at this point in our country, various analogs, 50 to 100 times more potent than heroin, which doesn't show up a lot. And actually in Summit County, in our data, I'll show you in a moment, it doesn't show up at all. People are not dying from heroin, they're dying from fentanyl. But you'll see here that we've got cocaine, you've got methamphetamine. Those are, as you see from the title here, are eclipsing the deaths from prescription opioids or opiates or heroin. So there's a definite problem arising nationwide in Cuyahoga County and in Summit County. So it's just something to pay attention to. Real quickly, things we often don't review for ourselves, a little bit about cocaine, and then I'll also do methamphetamine. You'll notice here that what we're talking about is blocking the reuptake of the three big stimulating neurotransmitters. So just be aware that's why. So when we give an SSRI, we're purposely keeping serotonin higher in the synapse. And, we're talking nanoseconds, but that makes a world of difference for individuals with depression, anxiety, and sometimes other illnesses. Notice when you switch to cocaine, from cocaine to methamphetamine, that it actually increases the release and blocks the reuptake. So hence they get that, as patients will say, that blast. It's a different effect. And therefore, although they're both stimulants, you're getting a different effect from methamphetamine, think Breaking Bad, than you are from cocaine. But both are on the rise. So just please be aware of that for your practices. Treating this, and again, I'm giving you just quick summary slides from we're all long full hour talks. Treatment, you'll see here, benzodiazepines come in high. This is all evidence-based for agitation, also for the hypertension, interestingly. So that makes a difference for individuals with hypertension, hyperthermia. So notice, there's a theme here, right? But they can give other substances as well. But when we're talking ER, Dr. Tracy's an ER doctor by background, this is what they're going to give the person to try to calm them down in an emergency setting until the substance starts to leave their body and the effect leaves their body and they can return to a more normal baseline. So Dr. Manning took this and moved it into the jail setting. where he does a lot of work, at least every Friday, if not more often, up there at the Cuyahoga County Jail. And so he talked about expanding access. So this is a big issue. We started with a problem with opiate epidemic, and we discovered that there were a lot of places people were not getting access to state-of-the-art treatment. And jails and prisons were one of those settings, because the treatment, the MAT, of course, is also potentially using substances that could be used or misused and feed, in some instances, the illness of addiction. So again, it is a brain disease. So he was talking about how we can walk through this and then at the end have a warm handoff. You'll see here that part of his focus is around racial disparities, which is, of course, an ongoing topic and should be in our country. We need to get past that, just like we need to get past the stigma of healthcare, mental health care, and substance use healthcare. We just need to have healthcare. So we need to do that for everybody, irrespective of their genetic background, basically. And so you'll see here the disparity, though, that unfortunately Black or African American individuals are the highest group who end up incarcerated in jails per 100,000. That's quite a statement. And imagine, because there aren't that many individuals from the American Indian or Alaskan Native background in our country, and notice that they are second. So it's really a problem. There's definitely a disparity here, and it probably requires a lot more detail, but they all need care, and his focus, as it should be, is on care. And so you'll see just their key takeaway points from both of their talks is that you may need to use benzodiazepines to treat the stimulant use, the acute intoxication phase. The treatment does improve long-term outcomes, and I think that's important. So although we don't officially do MAT, and there are studies ongoing now about using stimulants of a sort for MAT for stimulant use disorders, they're not conclusive at this point yet. And then the ASAM criteria that everybody talks about does advocate for evidence-based MAT for everybody who is incarcerated. So this needs to be provided in any setting, including incarceration settings. You've all heard a great talk already by Dr. Torum in this forum, so I'm not going to take time with that now, but his talk, he's agreed, will be also on our website. Dr. Farvar from Cleveland Clinic Akron General then talked about anxiety disorders. He talked about of course, it's an evolved biological mechanism in our brain, and there's reasons for it, right? We need to have some anxiety. We do not want to have zero anxiety. We would not accomplish anything in life. And so you need to have the healthy amount of anxiety, not too little and not too much. And then he talked about the link between fear and euphoria. He gave examples of a plane crash versus a roller coaster. Same kind of feelings, but at least the roller coaster, you know you're going to land well, as it were. Whereas in a plane crash, of course, you would not. So they've studied such issues with our limbic system and so forth. So the normal anxiety is very important, and we do not want to completely eliminate it, because anxiety is a powerful motivator, right? We need to have this to drive us on any given day. Before giving a talk like this, of course, I should have anxiety. If I don't have any at all, I'm going to just sit here and not care, right? I won't prepare the talk well. I won't do that. So we need to have that as a driver. The other reason that this was included in this year, it was the 8th annual Integrated Care Conference, is that anxiety disorders are the most prevalent in our country. Very, very important as a takeaway message. This is a problem, and of course, it has increased under COVID. There's been more anxiety and really more outright fear in a number of individuals across our society, both fear of the virus and, of course, in some cases, fear of the vaccine, which has caused all sorts of problems. And then we do now differentiate. The DSM-5 has separated anxiety disorders from PTSD and obsessive compulsive disorder. We're looking at them differently based on research and based on the brain. We are excellent at treating the symptom of anxiety. We do this in many, many situations. However, we get into issues potentially, going back to that first talk, about substance use disorders, all right? Because people, their brains if you will, everybody's brain will like a Xanax or similar, because it greatly increases the GABA system, and suddenly you feel a sense of calm. And that, of course, if some people's brains, they have a genetic vulnerability to anxiety, they also have one to possibly developing a substance use disorder from that issue. And panic is what we often hear in our own offices, people coming in and talking about they had a horrible experience. Perhaps they were standing in line at the grocery store and suddenly they feel like doom and gloom is about to occur. Their heart is racing, they feel it pounding, their palms are sweaty, their mouth becomes dry, and they really lose perspective. And they don't realize they're standing in a grocery store line at that point. And so it's overwhelming. They actually may say they think they're about to have a heart attack. And so that's a huge issue. And unfortunately, this can then trigger the possibility of anticipatory anxiety. So now they anticipate this could happen again at the grocery store. And eventually that can expand to any setting. So now you have a generalized anxiety disorder along with this panic, which unfortunately can lead to agoraphobia, where people won't even leave the house. So this is very much more common in American culture than we realize. The most effective treatment is CBT, cognitive behavioral therapy. It is not medications. And we lose sight of that in this country in particular. Everybody wants a pill. They want it yesterday. And they want a pill now. Just give me a pill before I go grocery shopping. I'll take my Xanax or my Ativan and I won't have that problem, right? Well, no, we need to work with you because this could be a lifelong issue. As I've just quickly described, it can go on to causing greater problems, such as not even leaving the house. So just a big takeaway I thought was that cognitive behavioral therapy, you're probably all aware that Dr. Beck, who created all of this, just passed away at the ripe age of 100. So he gave a lot of great contributions to us, including particularly cognitive behavioral therapy after he had created the Beck Depression Inventory. So there are other medications, however, that do work, and they do not have to be benzodiazepines. Therefore, we do not have to necessarily take the risk that we might develop a substance use disorder, a benzodiazepine use disorder in individuals because they have anxiety. So you'll see selective serotonin reuptake inhibitors, selective norepinephrine reuptake inhibitors. They're actually still mostly serotonin, as you know. So those are very important. The studies show that venlafaxine is actually a stronger version here and maybe better, therefore, for dealing with the anxiety. All right. You've also heard me, not Amy Wade, who did this with me, our executive director now, but we've talked about this. I'll just show you a slide because it matches some of the other slides I'm showing you. That fentanyl, this is a little updated since I showed it to you last, that fentanyl is still our largest cause of death as determined by the medical examiner, Dr. Lisa Kohler. She and her team are excellent in Summit County. But notice, again, matching what you saw from Dr. Tracy's slides there, methamphetamine and cocaine. Notice what's not on this slide anywhere is heroin, right? There's a few pills, and often that's elderly people who end up overusing their pills. Alcohol is not gone, and I say that because I'm going to now talk about alcohol. So Dr. Cohen did a great talk about alcoholic liver disease. He focused, as you see here, on alcoholic hepatitis. The alcohol liver disease is the oldest form of liver disease. Notice, I didn't even know this till he gave the talk, that fermented beverages go back at least to 10,000 BC. And that means, that's using the older terminology, that means it goes back 12,000 years, as I now say, BCE, before the COVID era. My new version of BCE, but 4 to 5% in the United States meet criteria for alcohol use, abuse or dependence, which now is use disorder, mild, moderate, severe. We tend to think of the dependence more equating with the severe version of a substance use disorder. A lot of deaths are coming from this in the country. And look at this, 3 million in the world in 2016. Which is more than hypertension and diabetes combined. So although I and others have focused on opiates, the truth is that more people die every year, even in our worst times of opiate epidemic, from alcohol-related disease, and even more than that die from tobacco-related disease, which I won't talk about today. So alcohol use disorder, you'll see that he kind of took the epidemiology here, and he has seen, we've all seen, increase in hospitalizations from alcohol, liver disease during COVID. So he showed a lot of statistics on this, which there's no time for today, but just be aware that indeed that also has increased, which matches anxiety increases in COVID, because ultimately alcohol is seen by the brain very similar to what it sees for a benzodiazepine. So they both end up increasing GABA, the neurotransmitter, which is our calming, or the main, maybe the only, although I hope there's others, calming neurotransmitters that we're aware of in the brain. So they've been looking at this data. This is university hospitals, Case Western Reserve, looking at the incidence, and you'll notice the increases here. That's a pretty big jump. That's pre-COVID. So this is going up and up and up. More women in particular, I'll show you that. One of the other speakers that I'll quickly paraphrase talked about that. And despite all this alcohol use, which is the biggest risk factor, 6 to 41%, so different studies, will develop cirrhosis. So there's the issue of the repeated cycle of damage to the liver, which then leads to cirrhosis, which is basically scarring, but can of course destroy the liver, is a huge issue that's being looked at, not usually by psychiatrists or even primary care doctors. It gets into specialists at that point because it's so severe. So here's a continuum of this whole process here, from asymptomatic fatty liver, as they say, liver changes. You can get into the alcoholic hepatitis, where there are a lot of symptoms. The labs are obvious. The physical exam is obvious. You can palpate the liver on physical exam, and then the scarring, which also is a problem. And that really is where you start to see the biggest problems for individuals as they go further into their alcohol use disorder. The alcoholic hepatitis mortality is increasing, not decreasing, despite improvements in our science. So that's a huge problem. So we need to make sure that emergency rooms and others are able to identify alcoholic hepatitis. And then, of course, how do you treat it? Well, lack of alcohol is the best treatment. They do other things to actually deal with the liver itself, such as steroids, even transplants. But ultimately, we need to all work together as a team, integrated care. That's why we're all here today, to really help work with the person around what the risks are going forward, why they should remain abstinence, getting into motivational interviewing. We've had talks on that here as well. So I think that one actually ties a lot together for this particular group. And then finally, another talk we had, again, we had not focused on alcohol in much in our other 7 years. So we made sure to focus on that some in the 8th year. So alcohol use disorder in women, Dr. Rob talked about this. And notice this, I was struck by this. Nearly half of adult US women report drinking in the past 30 days. Now, that does not mean excessive drinking. That means they had a drink, but that means that it's, again, alcohol use is, not only has it been around for 10,000, well, I guess that's now 12,000 years, but it's common, it's daily. If this is an event that we have decided is societally acceptable. And of course, there's studies out there trying to prove whether some alcohol is good, how much is bad, how much is good, how much is bad. In the recent 5 years, I've seen many conflicting studies from, a drink or two a day is great for you, to any alcohol is bad for you. And I guess it depends on the perspective you're looking at. So just be aware of that for yourselves and for your patients. Now, notice that even in high school students, where in theory it's illegal because they're not old enough. It was 18 when I was in high school. It's moved to 21, I think virtually everywhere. But you'll notice how many, and again, more women, more females, I guess they're at that point, they're not quite women yet, but more females than male students consuming alcohol in these studies. And these are anonymous studies. So presumably the same number of individual percentage who don't trust that it's going to be anonymous, men and women, are going to equally say that. So it's probably an underestimate, quite frankly, not an overestimate. So we know, here's the big takeaway, decreased life expectancy. So whatever study you want to look at, the net result is drinking alcohol leads to shorter life expectancy, not a longer life expectancy. And a lot of that is because of the alcohol-related medical problems, some of which I just talked about from the prior lecturer. A lot of problems, of course, brain. So I always am worried about the brain components from the psychiatry perspective, and we see that. We did actually have a talk on Wernicke encephalopathy, which is, again, not in today's slides that I didn't receive permission or the slide set yet to do that. So once we get that permission, we will also post that to the ADM website. A lot of co-occurring disorders in women who use alcohol, not surprisingly, is depression, since alcohol is a depressant. So that's a problem, and that often takes a lot of education with an individual who's having the alcohol use disorder. But not surprisingly, anxiety disorders, suicidal ideation and attempts are in there, and other things that we associate with anxiety, guilt and shame, and self-esteem. Eating disorders fall squarely into a lot of that as well. Oops. Okay, so there is a brief interventions that Dr. Rob talked about, which I thought were important just to show you real fast here. So obviously assessing, this is focused on women, although a lot of this would apply to men as well, but assessing the drinking, giving the information, empathic and non-confrontational manner. Because again, the part of the difficulty with alcohol is it's legal, and it's always been legal other than our poor attempt at prohibition. And so it's not seen as a barrier to use in our society, which unfortunately, if you are predisposed to develop an alcohol use disorder, is a negative thing. And that kind of gets into my thoughts around marijuana, which I won't go into today, but that's always been illegal. So making it legal is going to open up the same problems around that we've had around alcohol since alcohol existed, basically, long before we had very many laws and rules. And then finally, what are some of the barriers that we can reduce barriers in terms of getting people into care? We may need to help them get childcare, right? Prenatal care, very huge, trying to work with women who are already using alcohol too much, so mild, moderate, or severely in the use disorder category. How do we help them in the time that they've just gotten pregnant, which unfortunately often they don't even know they're pregnant until they've been several weeks into it, which may mean they've already affected the developing fetus. So there's a lot of issues that need intervention at this point in time. There's a lot of female specific content programs that they've found success in treating women selectively as a group together without having a co-ed group. So that's also very important. And finally, I've actually pulled this from Dr. Manning's slide, but I thought this was a great conclusion today. If a 0.1 micron virus can change the course of human progress, why can't we? And I think that, to me, I thought, what a great ending to this, because clearly we've seen the power of something that we can barely see and what it affects us. And why don't we be proactive around some of these diseases and issues with our society? And I will take questions.